Hello, my name is Dr. Mary E. Money. I'm a board certified internist. I've been practicing in Hagerstown, Maryland since 1979 as a primary care provider. In 2021, I transitioned and started a consultation service by telemedicine. What I like to do today is provide an update regarding the digoxin monitoring. I want to pose the question and provide the evidence to support this. Are the current digoxin monitoring guidelines harming and potentially killing our seniors? So what are the current recommendations regarding digoxin monitoring? Believe it or not, the only current recommendations for digoxin monitoring is for possible toxicity or to assess compliance. This is true. The monitoring recommendations for the FDA guidance, and this is where it's sourced, is to recommend to monitor for signs and symptoms of dish toxicity and clinical response. And the levels that they have stated is 0.5 to 2.0 nanograms per milliliter. But you notice they're not saying to monitor after starting any additional medications. Just monitor if you think that they're toxic. Aren't there guidelines right now to monitor digoxin frequently like other narrow therapeutic drugs? And the drugs that are most commonly thought of is warfarin as well as lithium. There's very clear guidelines. And there aren't any. This is a negative statement. We do not have guidelines to monitor digoxin after starting other medications. So the digoxin's current therapeutic range from 0.5 to 2.0 in the FDA's digoxin labeling report is based upon the 1960s observational data on hospitalized patients taking digoxin regarding toxicity. This is a true statement, okay? We came up with those numbers based upon information that was determined by patients who were admitted to the Mass General Hospital from September 1968 through December 1969. That's the only way that this value came up, and it has not been revisited, since that time. So they looked at 131 patients who had no symptoms of toxicity. All these patients were hospitalized with ditch at the time. They found only 48 patients who had cardiac rhythmic changes compatible with toxicity, and it came up with this range. So which of the following statements is true? If the serum dig level exceeds 0.9 nanograms per milliliter, there's an increased risk of mortality based upon a 2015 meta-analysis of 52 studies involving 621,845 patients. Second statement, an observational post hoc analysis of serum digoxin levels obtained at the time of enrollment for the Aristotle trial comparing apixaban to warfarin for atrial fibrillation identified that dig levels less than 0.9 resulted in no increased mortality. But if greater than 1.2, there was a 56% increased risk of death. Now note that this is a post hoc analysis of serum dig levels that were done at the time of enrollment. And then they looked at what happened to these patients ongoing and found that there was an increased risk of death if their levels were greater than 1.2 at the time of enrollment. These were patients who were already on ditch. Follow-up dig levels were not reviewed. And the third question, or third statement, several guidelines now recommend a therapeutic range of 0.5 to 0.9. Notice this is not 2.0, but 0.9 nanograms per milliliter for ditch, but numerous laboratories have not updated their reference ranges. So what happens if they don't update their reference range? And a provider sees a report saying that the dig level was, let's hypothesize, 0.8, and the reference range says it should be 1 to 2, then that provider may double the amount of dig without realizing that they're causing harm. So which of the following statements were true? All of them were true. Now the published guidelines, there have been published guidelines for lowering the digoxin therapeutic levels for efficacy, and these are the three that have already been published. Okay, you'll see that the European Society for Cardiology in 2008 recommended a lower standard of 0.6 to 1.2. And then in 2013, it was 0.5 to 0.9. And now in 2021, the guidelines that have been published recommend a DIG level of less than 1.0 nanograms per milliliter. Now, I looked at and called several different laboratories to find out what they actually had as their current values. And these are the reports. Note that this was back in the winter that I called them, winter of 2023, so they may have updated them then. But as you can note, several of them continue to have very elevated lower levels for DIG. So if a person had a level of 0.7, for instance, and they contacted Brigham and Women's Hospital, they might be told that that was insufficient, and the provider, without appropriate knowledge of the fact that the new recommendation values are higher, or actually at a lower value, might double the medicine. So this is a major problem right now. Up to date actually recommends that the levels to be less than 1.0 nanograms per milliliter, but does not make a recommendation on how often or when DIG should be monitored. This is true. So what are the consequences of the lack of clear recommendations for monitoring the DIG level? The biggest one is increased harm to our patients taking DIG. There's an increased number of deaths with DIG compared to other narrow therapeutic drugs. I'm going to demonstrate that in a minute. And an inability to recognize digoxin toxicity clinically. So the U.S. Poison Center's National Poison Control tabulated deaths due to specific drugs from 2012 to and including 2020, and these were the values for these three drugs. Now, if you notice, digoxin is 228 deaths during this time period compared to warfarin's 4 and lithium 28. And this is the annual information. If you want to look it up, we've tabulated these separately. Even the number of cases using digoxin, which is the only cardiac glycoside, decreased from 1652 in 2012 down to 1043, and yet the number of deaths continued to be high. So digoxin facts, true or false? Over 400 medications may affect the DIG level. Over 400 medications. Is this true or is this false? Well, it's true. True or false? The electronic health records interaction checker will show all but the potential drug to digoxin interactions. True or false? This is false. It turns out that as we analyze the number of drug-drug reactions that were listed under these separate sources that you can compare the toxicities, Lexicon, which is what Epic uses, has only 139 compared to drugs.com, which is 416. So why is DIG still being prescribed since it's no longer being recommended for heart failure? The key reason is that it's still very valuable to control that rapid response of atrial fib, which unfortunately our seniors may not be able to tolerate the current medications to control atrial fib without it dropping their blood pressure. Now, atrial fib actually increases as the population ages. And as you note here, from 2019 to 2022, to the end of that year, the percentage of patients with atrial fib in EPIC, this was source that came from Epic Cosmos, has remained approximately the same. So the incidence of atrial fib is not decreasing. And likewise, the percentage of patients, again, from data mined from Epic Cosmos, has remained stable. Okay, so we're still using DIG for rate control. So let's talk about digoxin toxicity, and let's review that. True or false? Digoxin toxicity is easy to recognize. Most providers routinely monitor digoxin levels. Well, really? No, this is false. Digoxin toxicity is not easy to recognize at all, and most providers don't think about it. It's not included in the differential diagnosis. Now, the reason I got involved with researching DIGE was because I was asked to consult on one of my former patients who had been sick for 6 months. When I transitioned from primary care, she had to transition to a new primary care provider. And her new provider started her on several different medications. Her last serum digoxin level was done in October of 2021. And by the time they consulted me in August of 2023, she had been on multiple different medicines, has seen multiple different providers, was vomiting, was getting sick, didn't feel like getting out of the bed, was confused. The family thought she was depressed. They thought it was Trulicity. Also, she had been given doxycycline because of Lyme disease. And when I recognized that she had not had a recent DIGE level, I ordered one and asked her to not take the DIGE before she went into the lab. At that time, her DIGE level was 3.31. Her prior level had been within a therapeutic range, and back in 2021, her values were 0.66 and 0.81, and her rate was controlled. So that is how I got involved with this. And I have a few additional questions, and then I'm going to present some information that we did on a retrospective review of patients who were hospitalized with DIGE toxicity at our Meritus Medical Center. So here's the question. If a patient is started on digoxin in the hospital for rate control of rapid atrial fibrillation, they routinely have a serum DIGE level checked within a week of discharge. True or false? And digoxin toxicity is easily recognized in the emergency room. True or false? Patients are getting serum DIGE levels checked routinely every 3 to 4 months. True or false? Well, all these statements are false. We completed a retrospective review of all the patients who were hospitalized at the Meritus Medical Center between April the 1st, 2019 and April the 1st of 2022. And the following slides are going to present this evidence of what we found. So there were 79 patients who had panic digoxin levels greater than 2, but it accounted for 86 episodes. 7 patients were actually hospitalized 2 times with DIGE toxicity. Okay, 31 out of the 86 had panic levels because their testing was done immediately or within 72 hours of being given a DIGE loading dose because of rapid atrial fib. So 55 patients were evaluated in 55 episodes were in the emergency room, which consisted of 52 patients, because again, there were patients who came in 2 times, okay? 1 out of the 86 was actually followed in the ICU and had serial digoxin levels done because the intensivist was concerned about DIGE toxicity and identified it when it developed. Out of the patients who were seen in the emergency room, if you go into the bottom line, only 22 patients out of 55 were properly identified or suspected of having DIGE toxicity by the ER doctor. 2 of the 55 were referred to the emergency room because of known elevation of the DIGE level. And we did further analysis of this. The DIGE toxicity is not included in the differential in most of the cases, and particularly in our study, it wasn't included in the emergency room evaluation. One patient actually turned 1 week later from being in the emergency room and told the providers that he thought it was DIGE toxic. He had been diagnosed as having acute gastroenteritis. This is an overview of the symptoms that were present among those patients who were presenting to the ER with DIGE toxicity. GI was more prominent than cardiac, and general symptoms of being unable to get out of bed, being confused, being dizzy, being lightheaded, being nauseated, any of those type of symptoms, that was almost equal to cardiac. So even though we're taught that you look for bradycardia, that's not necessarily going to be the case. Now, the patient characteristics, by the time we did our review of these charts, okay, which was a 3-year period of time that we looked at all the patients who had the elevated DIGE level greater than 2, 33 had been deceased, okay, or 63%. We cannot say that it was due to digoxin because these were chronically ill patients. We tried to look and see what the DIGE level was prior to admission, if known. And we couldn't find it in 23 patients. We couldn't find it by reviewing the electronic health records. Okay, and among 15 out of the group, there were levels greater than the current recommendations. We also looked at the prescription medications that were taken by each patient and found that polypharmacy was a major problem. 38 patients had more than 10 prescription medications. These are just prescription medications, not the over-the-counter medications. So the key points from this retrospective review are here. 31 cases were elevated due to blood being drawn after a loading dose of DIGE was administered in the hospital for rate control, okay, and that's not appropriate. And 15 or 27% of the patients presented with DIGE toxicity. They had been started on DIGE in the hospital previously for atrial fibrillation and had no follow-up DIGE level done in the interval between the time that they were discharged and the time that they were readmitted. Okay. We also identified that in 58% there were new medications that were started prior to the patient being diagnosed with digoxin toxicity, and we feel that this may be a reaction to a drug-drug reaction with these medications. These drug classes included antibiotics, antidiuretics, proton pump inhibitors, antiarrhythmics, and we could not find that any DIGE level had been done after they've been started on these medications. So therefore, I am proposing that we need to have a major paradigm shift away from monitoring only for toxicity, and now we need to start monitoring for efficacy. As a result of our research, we have proposed updated recommendations for digoxin. And we have a publication that has been accepted and is recently published. These are our proposed guidelines for hospitalized patients. Do not check a serum DIGE level after you administer a loading dose of DIGE or after you administer DIGE immune fab. That's just not necessary. DIGE levels should be obtained on everyone who's admitted to the hospital, and subsequent levels should be done 24 to 48 hours to monitor for DIGE toxicity if new drugs are started. This is on everyone who is on digoxin, obviously. A standing order for digoxin, for a serum digoxin level, should be given to patients who are on DIGE so that if they go to the dentist, the podiatrist, an urgent care facility, they should be educated that 1 week after starting that new medication, they should get a serum DIGE level. I also recommend that patients' education, that they were provided education in a medical alert bracelet be worn so they know that when they go in, people will know that they're taking DIGE. Because too often, I think the emergency room doctors are not aware of the medications that the patients are taking and don't think about DIGE toxicity. Now, it is important for the patients to be educated that the timing that they should take their DIGE should be in the evening. That way, when they go in the morning to have their blood level done, it is at least 8 hours after their last dose. I also strongly recommend that we encourage each of our labs to update the current recommendations. And this is what I would recommend. The language should be the recommended therapeutic range for DIGE is 0.5 to 0.9 nanograms per milliliter. There is an increased risk for complications or mortality greater than 0.9 and an increased risk for toxicity if they're over 2. Now, some patients may need to have a serum DIGE level 1.1, and that's perfectly appropriate if they're being monitored closely and assured that they're not having DIGE toxicity. They may need that extra amount for rate control. Likewise, a level less than 0.5 may be efficacious for some patients, and clinical evaluation is warranted before you automatically increase the dose. Key thing is the interactions with DIGE with other drugs. So before prescribing a new medication, providers should perform a careful medication history and evaluate for drug-drug interactions. Many of our electronic health record systems, depending upon their sensitivity, may not list the reactions, therefore it's just better if any drug is started for the patient to have a repeat level in 7 to 10 days. A summary of these guidelines is as follows. Confirm that the patient's DIGE level is in the therapeutic range of 0.5 to 0.9, ideally. When a provider suspects toxicity or presents to the urgent care or the emergency room, get a DIGE level. If you're going to check kidney function on a patient who is on DIGE, then include the DIGE level and the serum magnesium at the same time, since a low magnesium can affect it. 1 week after starting any new medication or discharge from the hospital on DIGE, the level should be done, and the patient should have the standing order for Digoxin reminded to take it in the evening. Now, we have published an open access manuscript on Digoxin, and everything that I have discussed right now is included in this document. I would encourage everyone to download your own copy and to review it. Thank you very much for watching this. Feel free to contact me if you have any questions. Stay well.